I'm a neurosurgeon. So these are people around 200 from different countries, and almost 300 people hear me every day. This is the maximum Zoom limit I can speak. So we are putting you both on my Facebook and Zoom so that everyone can hear what you are speaking. Put it on.
Yes, sir.
Here. So you are hearing to my medical director. He is a senior neurosurgeon. So that I told you, sir, I'll take you to 300 people in 1 minute. By tomorrow evening, you'll reach 20,000 people. See, the problem here is with us is that, sir, the surgeries what we get are destroyed surgeries. If people reach to a right neurosurgeon, then the recovery becomes very easy. So our work is to take you there so that at least again and again answering many questions that have not come to us. So sir will be speaking 1 minute once the mic is adjusted.
Yeah.
We adjusted. Just take me that video. No? You don't know how to take.
No, it is already, sir.
You are doing it. Are you taking me?
Yes, sir.
Already
was gone. No?
You're taking me this video?
Yes, sir.
Okay. Sir, please speak.
So, myself, Dr. Lakshmanath, I'm neurosurgeon in Hyderabad, based on Hyderabad. I'm practicing in Continental Hospital. So, rehabilitation and recovery, it is the integral part of the neurosurgery. And you say it is the extension of the neurosurgery. Yeah, it is the rehabilitation. It should be the must and should be the end goal of every neurosurgery procedure. See, we operate that basically for a tissue diagnosis or for a tumor removal or a blood clot removal or removal of a hydrocephalus, meaning CSF let out or whatever, or spinal cord injury stabilization. But finally, what nowadays, if you come from the patient perspective or relative, every relative or the patient, they want to be functionally to become normal and whether they can lead a normal life, and they should come to almost to their normal life. But it purely or most of time it depends on the rehabilitation program or the one who is doing this recovery program, and it should be in parallel with the neurosurgeon. And from the day onwards, I generally encourage a neuro rehabilitation programmer or neuro recovery programmer should work along with the neurosurgeon from the day when the patient comes across. So we should have goal before the surgery itself. The surgeon should discuss with the physiotherapist or recovery guy, and both should discuss with the people, with the patient and the relative, what's going to happen with the patient, why we are going for the surgery, and what could be the recovery, and when could be he will become normal. So we should have time frame, and we should work in that time frame. We should give positive counseling. So it will come from the before the surgery hand and during the surgery and after the surgery also. This recovery thing, it should include all the aspects, their psychological, emotional, and physical, all the aspects. So daily we are seeing, I have so many patients now, at least 4 to 5 patients. Now one patient with aneurysm bleed, patient is on ventilator. She had quadriplegia with, she has, but the cognition is intact. So daily we are instructing to our rehabilitation programmers to look after her basic limb care, limb physiotherapy, and not only limb physiotherapy, they also have to include tracheostomy care, speech therapy, and they should be in a position to deal with even kind of a swallowing difference. So this recovery or rehabilitation should include even the respiratory mechanism or respiratory angle also. Nowadays, one guy will deal with respiratory therapy, that guy will deal with swallowing reflex or tracheostomy, another guy deal with the ambulation, limb physiotherapy, but both should include in one domain so that you can deal with the patient holistically. We can give overall treatment. That's one aspect. And it also includes speech therapy. From the day onwards, when we are operating on a dominant hemisphere, left, when basically the problem involves the left side of the brain, speech area. So these people, they won't respond properly verbally. So recovery or physiotherapist guys should have that capacity to deal with these patients and how to communicate with these patients. When the speech program or speech domain, speech area, it got affected with the injury, with the tumor. So how to, we have to communicate with the patient, and that communication should be in a perfect way so that patient can understand what you are training, what you are going to do, how you are going to train, and how we can improve fast. That's the one brain. And then again, spinal cord injuries, various spinal cord injuries, and it should be myth that all spinal cord injuries are, they will be bedridden or wheelchair bound. No, we should tell everyone that with all the advanced technology or with the newer therapeutics, we should make every patient to ambulate or he should walk himself. It should be our primary aim. Anything else? Anything, any question?
They have a question about brain mapping.
Brain mapping, I'm very much interested in brain mapping. Actually, I used to operate brain tumors without anesthesia. I won't give anesthesia to my brain tumor cases, most of them. What we do is, our anesthetist, we give scalp block here, and we will make the patient in. Why this procedure is not a new one? It has been there for last at least 25, 30 years, but I got opportunity to do more cases in my training program and in my experience in my where I worked in prestigious institutes. So here, everyone's person is a neuro, what do you say, when we are dealing with the brain tumors, after surgery, what could be the patient condition? Everyone will ask, what could be his, is he going to develop hemiplegia? Is she going to develop any speech problem? She is going to become conscious. So how to deal with these questions? So when you are putting the patient in anesthesia, complete anesthesia, and when operation surgery was done, when you remove the tumor, patient is become hemiplegic. So we don't know what happened. So what we do is, we have to map with the electrodes. We have to, that is called cortical stimulation. We have to we have to stimulate the cortical areas, and we have to intraoperatively, we call it is neuro monitoring. We will get all the signals. We know which area is the stimulating area and the positive area, that is eloquent cortex. We call eloquent cortex. When the cortex is stimulating, it becomes positive signal. So we should not operate in that positive area. We should operate only in the where the cortical stimulation become negative, and when the tumor is in the negative area. And during the surgery itself, we have to ask the patient to talk. Some patients may be singers, some patients may be lecturers, some patients may be teachers. So when they have involved in the speech area, so their main concern is you do surgery, but what will happen if my speech area is affected? So post surgery, how can I perform my duty? How can I join my job? So what we do is during surgery itself, we will ask them to talk continuously. We will ask the questions. They will going to answer, or we will give the song. They will sing during the surgery itself. So while during surgery they have problem in performing the task, we will stop in that area and we will go for another area of brain too. So basically the main fundamental principle here, brain mapping, and these surgeries called awake brain tumor surgeries. Patient is awake. So main fundamental principle here is we have to remove the tumor. At the same time, we have to keep the patient functions intact. Patient, we will ask the patient continuously move his hand, opposite leg. Whenever he develops little bit difficulty, we will stop. So last few months, I have done one patient. He came all the way from Chennai. He had left side supplementary motor area tumor. So he came all the way from Chennai. It involves the left side, left frontal motor area, left supplementary motor area. So patient is awake. I removed almost 80% of the tumor. And when the patient is developing his right, because it is on the left side, he has a right-handed brain. So right side wrist, he is developing little bit of weakness. So I stopped. So they went to Chennai, they went to radiation therapy. Everyone is really wondered, how come entire tumor, almost 80% got removed. So if you are in general anesthesia, because you have fear of giving hemiplegia, what people do, they do just biopsy of some piece. They won't remove tumor. Here, because patient is awake, I know what I am going to give any deficit. So I can go as much. So I removed almost 80% of the tumor and remaining 20% it gone with radiation therapy and the patient is fine. And recently, 3 weeks back, I operated one more patient with, he is a cab driver. The tumor is on the right side, right motor cortex area. So during entire surgery, we will I did talking with him. Then I told him to move his legs and hands. So what happened is at one point of time he had a toe weakness. So meaning he perceived himself that there is some tightness is happening when I am going down. So almost I removed almost 90% of the tumor. So when he developed that tightness in his toe, then I stopped. So patient is totally fine, 90% removed. He has only difficulties with few days. He couldn't, he can walk, he can do all his work, but only thing is first few days he couldn't wear the footwear. Then he got improved immediately in a matter of by the time of suture removal by 10th day, it got improved. So because if he is under GA, I would have done some more tumor, I would have removed. Only for 5% tumor, patient would have developed entire leg weakness. So this awake surgery is very important, and at the same time, we can remove or we can take out of general anesthesia. It has a lot of expenditure and no ICU stay. All the brain tumors, these awake surgeries, I am discharging the patient the next day. And we will give food even within 2 hours. So no one knows that he got underwent brain tumor surgery. It is just like any other. So no ICU. Patient will come directly to keep observation for half an hour in the post-op recovery room. We will send him to normal ward. He can take food in the first half an hour time, and he will relax on the day. Next day he can go. If someone wants to go on the same day also, I am happy to send him on the same day. It is just like daycare surgery. So 2-3 things you can take from my talk on awake brain surgeries. One is maximum tumor we have to excise. At the same time, we should not give, or we can give only minimum deficit. Third thing is, it is very cost effective, very less cost because no ICU stay. There is no general anesthesia. Patient will go immediately to the ward. Cost is less. And fourth thing is duration. Patient is not going to stay. People will ask me after brain tumor surgery, how long patient should be on bed rest, when he will recover, how long it takes. Recovery. Patient is totally fine. Patient can go immediately, and my patient is a cab driver. He can go for cab driving next day itself. Yeah, I can show his picture.
अनिश को बोलो ये पिक्चर ना स्क्रीन में ट्रांसफर करें. Shri sir, we never planned for stem cell. Yesterday, this orthopedic surgeon who has left orthopedic surgery was saying, I have been doing stem cell. Within half an hour, we converted our room to a OT room and we started our practice.
He is the patient. I don't know whether he is the patient on first post-op. He is the patient with the brain tumor and the first.
Can you put that picture in TV?
Yeah. Yeah. See, he is more stylish than me. And on the day of future removal, no one knows that he got under. Wow. Seventh day suture removal.
Can you show? No, this is a brain tumor patient who is second day after surgery. Can you all see it? Can you see? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir. We can see.
Sir.
We can see, sir.
This person was operated with a patient was operated.
And I will show you that video.
Generally in China, we do it with the help of acupuncture and neuroanesthesia.
পারাসাইট আসছিল নাকি? পারাসাইট আসছে? আপনি দিবেন যায় নাকি? কই?
So I am operating now.
বুঝলাম না। কোত্থেকে আসছে? কি জন্য?
Yeah, this is the neuro navigation. We can see the tumor exactly during the surgery itself. So our anesthetist is talking with the patient.
Okay. Surgery sir. Just a little bit operation is required.
So we are discussing with the patient during the surgery. The patient is young, dynamic. I can give him during the surgery. He can walk. I can give him my mobile. He can watch.
Can you put on the TV? Mirroring is this much.
Mirror.
लाइब्रेरी में आपकी लाइब्रेरी में
See, this is sir. You having your patient also came.
स्किन का ऑफ है
ये मोबाइल से कास्ट करो.
ये सर का मोबाइल से सर का अंदर में जो वीडियो है उसको उस पर
वो जो भी बन जाएगा सर का मोबाइल से। Don't cost my mobile. My sir's mobile to be cost.
Any linked device?
न्यूरो देख लो
Sir mobile. Sir, give me my mobile. One minute, we are putting on the TV, you can see it clearly.
Wi-Fi, it's not.
Let me take तो स्क्रीन भी बड़ा दो सर
So I am doing neuro navigation, that is, so during intra surgery we will know where is the tumor, so where we have to put our incision so that the incision will be very less, very small, and then we are talking to the patient.
Voice.
What is finished?
So, yeah, so that is the video where we showed that how to we perform this awake craniotomy. We club with neuro navigation, so we can identify the tumor, real-time tumor identification during the surgery itself with the MRI, and that will make the incision very small incision, and the craniotomy is very less. So overall, the duration for the surgery will come down. Mostly 30 compared to normal surgeries, we can come down to 30 minutes to almost 45 minutes. We can come down. So less duration of the surgery, less morbidity, small incision, and with very high or maximum tumor excision with minimal deficits. So it has comprehensive goals and it has comprehensive benefit with the patient. A tumor load will come down. The patient will be functional immediately. There is no need of ICU stay. There is no general anesthesia. We can operate the patient with old patient or patient with comorbidities. If the patient has not suitable, not fit for general anesthesia, we can operate on the scalp flap. Then we can discharge him immediately. So it will come down on the hospital expenditure. Mostly patient will resume his work immediately. Next day, patient will join in his work. There is no need of any bed rest.
Sir, there is a paralysis patient over here. You examine him, and you examine him after 1 minute. See, the hemiplegic patient. Yeah. He's a poor patient. I don't even give MRI because I've not done it.
Oh, MRI not done. Just
No.
hemiplegia.
I don't know what is there in the brain. Very poor patient. They can't afford my, he's a father to watch me.
We can do at least a CT scan. Very
I
less
told
cost.
them,
Very
but
less
then
cost.
they disagreed.
Right.
So, money issue. How much is paid? 70,000. Most of my patients, I do a OPD of 150 patients. 100. Counseling time, I don't care. So, you see this patient, and after 3 minutes, you see this patient, no limbs.
They make him to stand and
He's finding difficulty to stand, finding difficulty to walk. After 1 minute, you see the difference. Can you give me the needle?
yes.
सर आवाज बढ़ाइए.
ये एक पैरालिसिस पेशेंट है, साथ में न्यूरोसर्जन है, and now you can see ये पेशेंट चल भी नहीं सकता ठीक से, वॉचमैन का पिताजी है, के पास ना कोई सीटी स्कैन करने के पैसे हैं, ना एमआरआई करने के पैसे हैं, and is paralytic, और मुझे इसको तुरंत ठीक करना है, at least to some extent by which you can climb staircases right now in 5 minutes or 3 minutes. And this is what we have changed. This is our business.
This one.
Your brain.
This one.
Yeah. Basically, just to stimulate.
So all three is successful. Huh?
Wow.
Sir,
Very
is
good.
an orthopedic surgeon.
Hello.
Is a neurosurgeon.
Good name.
Congrats.
I'm Dr. Lakshmi Nath.
Nice
Near
meeting you.
Continental Hospital.
Nice
Nearby.
meeting you.
Hyderabad.
Nice
Is
meeting
a
you.
senior most neurosurgeon. Is a junior of Dr. Picheli.
Oh, okay.
Yes.
Nice meeting you.
IP was in 5th year.
Ah.
He was in 2nd year.
अच्छा.
Since then, I got in between. Between 2 seniors, a junior.
Just now we did 3 stem cell procedures
Oh, great.
in last 2 hours.
Oh, great.
No, sir.
If you say yes or no, it will not affect me. I have to work with my eyes. So now you can walk. 10. Time. चलो सीढ़ी उठो. कुछ नहीं पकड़ना है, छोड़ो. चलो चलो सीढ़ी उठो. After 2 minutes, circumcision will be. वो दिखाओ staircase वो फेसबुक में दिखाओ वो कहाँ गया सोनिया
No, if he is not, is he able to come down without any support? Hoga? Is it okay? Are you able to come? नहीं, इसको पकड़ो. नहीं. हाँ?
ट्राई చేయండి.
इधर कष्ट करो. Just help him. Hold this.
Hey, Greg. हाँ क्या?
सर मैं किधर को चेक सर वीडियो ब्लॉक అవుతుంది
हमारी इंप्रूवमेंट
Very good. Thank you. आराम से. चलो. This one also, sir.
You can see another patient.
మీ అబ్బాయి ఉన్నాడా? అబ్బాయి హ్యాపీగా ఉన్నాడా? ఇంప్రూవ్మెంట్ తోటి హ్యాపీగా ఉన్నాడా? ఆ రోజు చెప్పినందుకు లేట్ కదా సార్ లేట్ గా వచ్చారు హైదరాబాద్. యువర్ ఇన్ నాట్ ఇన్ హైదరాబాద్. సార్ ఇస్ ఇన్ కరాడ్, సార్ ఇస్ ఇన్ అస్సాం సార్.
No, उठाओ उसको. बस हो गया. छोड़ो. हाँ छोड़ो. पेशेंट छोड़ो. हाँ वो. कमर पकड़ो. छोड़ो. गणेश पकड़. इसको ठीक से वॉक करो.
ఎట్లుంది నమ్మకం ఉందా నడుస్తున్నావా?
how much according to you? Sir, it was not to you. How much? What surgery was it? And
the surgery was for spontaneous intracerebral stoma. Patient came with GCS with the pupil dilated, and we gave just 1% survival benefit for. I spoke with the husband. I told 99% there is no chance for survival, but now patient is walk.
so post surgery, what do you see?
Post surgery patient who is hemiplegic, though he survived, he is not able to move her left hand.
No, here what do you see?
Now she is good. 60% is good. She is walking. She is able to stand. She is recovering.
So what do you see? What are recovery level?
Yeah.
So what general recovery and this recovery, what do you see?
Very big. And much recommendable.
So how do you see this patient? It is called the
என்னது என்னத்த
Good, the mic. And then she, neurosurgeon is speaking. Why are you speaking? Why are you speaking? Why is neurosurgeon, orthopedic surgeon are speaking? कैसा लगा? Now all the nurses confused 10 by 10. Hey, 1,000 rupees. I'll pay you back.
So you want 1,000 rupees, huh?
1,000.
I'll pay you back. Whatever you have given me, I'll just pay you back. Yes. I've collected so much.
She know you love so much.
Ragupala. Welcome, Ragupala phone number.
അവരുടെ അടുത്ത് നിന്ന് പേഷ്യന്റ് എന്ത്
Sir. Just all of you come inside. How you can contact sir, how to speak to sir. I one thing I tell you, it's just like more simple than IT schedule. You know, when I wrote my societal note, and I wrote, I'm an orphan, immediately a message came. My greatest remark is that in my obituary, I don't want to go as a orphan. In family, this would be like this. Yes. Someone is there behind me. And that's the best enjoyment of serving, sir. Its simplicity, its expressions. Anyone can contact him. Sir, you please put up your phone number so that people can talk to you. Sir.
Yeah, I'm Dr. Lakshminand. I'm a consultant neurosurgeon in Continental Hospital, Gachibowli, Hyderabad.
And also he is our medical director. So you please have his phone number.
Yes, my phone number is 888
sir.
plus 91
plus 91
888 44 36640.
So please repeat. Please write down in the chat box.
Plus 91 888 44 36640.
So if you have any international cases from Singapore, Malaysia, Indonesia, and if they cannot afford the cost of surgery there, which is very high.
We can operate all kind of brain and spinal cord surgeries with very lesser cost, with high technology, with new technology and highly sophisticated machines we have. Like we have high-end microscope, we have neuro navigation, and we have QSA, we have neuro monitoring, we have excellent ICU setup.
So if you have any cases, if you want any medical advice, just don't ask me about neurosurgery. I'm not a neurosurgeon. You may ask me about how to recover a patient, post-surgical. But if you want to ask any surgical question, there is available on WhatsApp. WhatsApp is your MRI. Save the patient, get operated on the first day. Maybe most of the cases will be discharged on the second day. That's the magic of CMC. Yes. Any questions anyone wants to ask? I repeat.
Participants or students, please, if you have any questions, sir is here. You can ask your question.
Ask question. You have a neurosurgeon, you may ask questions.
Good evening, sir.
Hi, tell me your question.
Sir, you tell me something about intracranial pressure and your subject.
See, intracranial pressure is that normal ICP intracranial pressure, that what we measure, that is around 20 mm. But it has significance value in case of diffuse axonal injury, where you won't see any kind of obvious hematoma or blood clot within the brain, but you don't know whether you have to do any decompressive craniectomy or you have to just manage conservatively. So we have to measure that raised ICP, that intracranial pressure. We have various methods. Traditionally, we used to tap the ventricle and we have to connect that to monitor. We generally, whatever we measure it, arterial blood pressure monitor, same dome we used to connect, and we have monitor that tells how much is the blood intracranial pressure. If the intracranial pressure is very high, we have to, in the same channel, we have a three-way connection and we will remove CSF. Maybe when the ICP is going high, about 20, we have to take out the 5 to 10 cc of CSF, or we have to give one shot of mannitol. So in the raised ICP, so it is helpful in case of diffuse axonal injury. It is helping for intraventricular hematomas, IVH we call, intraventricular hematomas, basal ganglionic hematomas with extension into the intracranial pressure, or subarachnoid hemorrhage. In these features, basically whenever you feel that intracranial pressure is high, you have to give one more shot of mannitol, or we can give mannitol continuously, Q4H, Q6H, and we have to take out the CSF, 5 to 10 cc of CSF we can take out. But nowadays, people not only intraventricular, some people non-invasively also they are monitoring with the subdural grid, with extradural grid. So many varieties of even non-invasive are coming up, and each one has its own pros and cons.
More questions?
Thank you, sir. Thank you, sir.
Thank you. Any more questions? You can ask.
Everyone has a number of sir. Everyone has the number of sir. Put down the number. One minute, sir. Say your number.
Yeah, I'll tell you. 888 444
44
888
44 366 40.
Dr.prakash. I given the number to you, and I hope everyone's doubt is clear. Any more questions? Any more questions?
Gee, what is the Dr. Vic's name?
Huh?
What's the surgeon's name?
I'm Lakshmi Nath.
Dr. Lakshminath.
Thank you.
So whatever surgeries you have in Singapore, which is very costly, you think you have to spend $50,000, $30,000. Here we can spend in $4,000 or $3,000.
Yes, sir.
So if you find that neurosurgery which cannot be done in Singapore or which cannot be done, says Rodney from Singapore.
Yes.
So those who cannot, आप ले जाइए ऊपर ले जाइए patient को. Tip the patient. So those who cannot be, those who cannot get operated internationally in Indonesia, Singapore, or China, they can contact me either, or sir will help you to the best. Sir will operate, post-operatively will recover, and I think at minimum cost, you can be recovered. I think 1/3 of the cost of Indonesia, China, America. America you forget. 1/3 cost, less than 1/3 cost. Because in Singapore, you run surgery in Singapore for brain.
I'm not sure the charges. I think 20,000, 30,000 maybe.
We can do it in 3,000 or 4,000.
Yes, yes. Definitely we will refer if there is a case.
So you can refer all the international cases. You are in my touch. Sir is our medical director. We'll help you with all support, post-operative, pre-operative, and we'll see that the patient goes walking to his home.
Right.
Right? So
yes, wonderful.
We quit this all from Philippines, Indonesia, Malaysia. We thank all of you for giving us time. We thank Dr. Lakshminath. Immediately on my call, he came. I'm happy. Thankful, sir. Thank you, all of you. Thank you so much.
Thank you.
We leave up.
Thank you, sir.
Thank you, sir.
Thank you so much, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, Ji.
Thank you.
Thank you, sir.
Good night,
Baik, Bu Bea.
Bu Mika, HP ku mati.
Nanti tak masukin.
Nggak bisa telepon.
Thank you, sir. Thank you.
Nggak apa-apa.
Thank you, sir.
Cara-cara